I'm Peggy O'Kane, president of NCQA. I founded NCQA 35 years ago. We've made a lot of progress, but as I prepare to leave NCQA, I feel there's unfinished business. That's where this podcast series comes in. I'll be talking with some of healthcare's brightest thinkers, executives, researchers, and innovators working for real change. These conversations are for people who are curious and want to help the U.S. escape bad health outcomes and runaway costs. This is Quality Talks. For the final episode in this podcast series, I'd like to share a conversation I had with my successor, NCQA's incoming president and CEO, Dr. Vivek Garg. Vivek and I spoke on stage at the final session of NCQA's Health Innovation Summit in October. As you listen to our discussion, I think you'll see why I'm convinced Vivek is the right leader to help NCQA and the quality community thrive. NCQA Board Chair John Glasser got the conversation started.
Good morning, everyone. It's a real privilege and an honor to be here with all of you for what is truly a historic occasion for NCQA. I've had the honor to be working alongside Peggy O'Kane for 9 years now. She's a visionary whose leadership has transformed the quality of healthcare in the United States. She's got this unwavering commitment that has touched countless lives and set the standard for excellence in this industry. Her legacy is exceptional. Today, we also look to the future as we welcome Dr. Vivek Garg, NCQA's incoming president and CEO. There are few people who have the talent, skill, and experience to carry on the work that Peggy has led for so many years at NCQA. Vivek is one of them. So it is my great honor to introduce two extraordinary leaders for this special conversation called Passing the Quality Torch. Please welcome Vivek Garg and Peggy O'Kane. Thank you.
Peggy and I made a pact last night at dinner that we were going to go off script. I feel like for the last few days, I've been visiting in the house that Peggy built. And it's been awesome. This community is awesome. This movement you've helped to create. I imagine that you're having reflections about this community, Peggy. But I just wanted to ask, what do you feel about this community?
I think this is a very unique community because whenever we are designing our strategy for the future, wouldn't happen without you all that make it happen. And sometimes we create standards or measures that are problematic, and you tell us. And you're so generous also with your feedback about what we should be thinking about that we haven't been. I just find it amazing to be in this kind of a role. I feel privileged to have this. That word has a bad connotation, but I mean it in the best sense. To be working with all of you, with our teams at NCQA, now with Vivek, I feel incredibly fortunate. Somewhere along the way, I had the gut instinct that we could write all the beautiful rules that we wanted, but if somebody didn't make it worthwhile for people to do the thing that we're talking about, people were just going to go and do what people are busy, and we're asking them to do above and beyond what they're, and to a fault, I think. And one of the things I like about the tech stuff is if we can get it straight, we can take a lot of the hamster wheel out of medical practice and out of medical teams. So we approach this with humility, and then people teach us how to do it better.
When you look back over the last 35 years, what other achievements are you really proud of?
You're going to ask me about the other part too, right? What could have been better?
We'll get there. We'll get there.
Okay.
I know you're always thinking ahead. We'll get to that part too.
I'm actually not going to be too modest.
I know you don't like to talk about your achievements. You're always focused on the ball.
The biggest achievement, quality, when I came out of graduate school, quality was PSROs, Professional Standards Review Organizations, which basically meant peer review, doctors reading each other's charts, and that is a silly way of thinking about quality because it bypasses all the structural things that are missing in the system. There's so much work to do to get this structural stuff, but we created the first national system of quality measurement. We created an accreditation program that the employers at the time sat at the table with us and helped us write. Those are very proud achievements. But the other thing that I really feel proud about is that maybe 5 years ago, we decided quality measurement is really not working the way it should be. It should be much more embedded in medical practice. The measures should flow from medical practice. And what we're really trying to do with quality measurement is have people look at their numbers and have that motivate the change in the way care is delivered. So has it been a perfect journey? No, but have we got people's attention with it? Yes, we did. Yes, we did.
I'd say so. I know you want to get to the next set of challenges, but before I go there, I have a few observations about you I wanted to share and get your reflection on, not to surprise you. I feel this quiet kindness and generosity of spirit from you. I also hear someone who is very clear-eyed and willing to look at things anew. And underneath it, this conviction. You're always thinking, how do we move forward? What's the problem set? Who needs to be engaged? What could this become? Were you born with these traits, or did they come along the way? And if so, how? And how can I learn them too?
I think part of it I was born with, to be honest. I have a strong personality, not everybody's taste. But in this role, I think it's been a tremendous asset, because I don't have to tell this group how hard it is to make quality happen, right? Or when times are tough and the CEOs of many companies are looking at where to cut the budget, quality pops up in their minds a whole lot. I feel proud of my own persistence, and like, if that one doesn't work, let's try it this way. Constantly rethinking the strategy. So, yeah.
Let me ask my future NCQA colleagues in the audience, do we get some of Peggy's persona right there? Yeah. Yeah. Okay. Now we'll get to what you wanted to get to, which is what should we be focused on next?
Well, we need to enlarge the conversation. We are in the business of changing quality measurement to be more salient, focused on more important issues, less burdensome. These things are going to take a while. But we also have to focus on the larger environment that these quality measures are deployed in. As long as we have such a fragmented, crazy delivery system, it's really hard to say this is an accountable entity. And when the accountable entity is a small medical practice, that's pretty hard to measure, right? They're so stressed and so on. So what we have to have is a policy environment that really makes it in everybody's interest to get the quality better. I'm one of the people that believes that if you do this right, if you eliminate all the crazy, squirrely stuff that goes on because of fragmentation, we are going to have much more affordable health care. That's obviously due to happen because it's so obvious.
Right.
Not at all.
It's not the default path.
Not at all.
So it's going to take that persistence.
Yeah. But I kind of took it, like anything that wasn't working, I took it as our challenge. And I think that part of what I say to you is you need to speak up and say, if you don't pay primary care doctors appropriately, we cannot do this work. They cannot do the work. If hospitals make more money by having readmissions than the penalty that they pay, guess what's going to happen? We have the most crazy reimbursement system in this country. It's not even neutral. It's actively working in the wrong direction. So I think you need to just stand up there, and you have the credibility of having worked at the plan level, at the primary care level, and I'm planning to talk about this a lot after I retire.
Wonderful.
So
Wonderful.
I'll be out there with a big mouth, and you can be the nice, polite person.
So you're finally going to say what you think.
Oh, no, that's not true. People know I say what I think.
I know. All right, we're entering the advice portion. You dropped a little bit of wisdom for me just there. Any other advice you want myself, your team, this community thinking about?
My admonition to all of us is we need to be much more intentionally working together. We're all very busy in our own organizations, but we have a message to carry to the American public, to health policy leaders, and to practitioners that we're with you, we want to make this work. We already spend twice as much as anybody else, and our results are really pathetic compared to their results. I think you are that kind of a person. So it's one of the reasons I feel so thrilled about Vivek. I just said to Vivek that I was talking about Kate McAvoy. I was on the board of the Milbank Fund when she was the chief operating officer, and she got offered this job. And I thought, how did they find the perfect person for this job? And it's such an important job. She runs the National Association of Medicaid Directors. And they have a lot of challenges, but she is such a strong leader and such a strong advocate for Medicaid and for the people that are enrolled that it's perfect. So,
Absolutely.
Yeah.
Thank you, Peggy. And there's that kindness and generosity of spirit. I was going to ask you why you're being so nice to me, but I think that's becoming obvious. Okay, should we flip the table a little bit?
Yeah.
Okay.
I want you to tell us about yourself, because Vivek's biography tells you a lot about why he comes with this heartfelt dedication to quality.
Thank you, Peggy. I'll share with a couple hundred of my closest friends. Before I was ever a physician, I was a son. I have a father who immigrated from India, set up shop first in Alabama and then pretty rural northern New Jersey where I grew up. Hospital, ICU, clinic, nursing home, sometimes home visits, sometimes all in the same day, definitely in the same week, 7 days a week for 4 decades. So I saw what being a clinician meant to him, being a doctor. We grew up in a pretty small town in northern New Jersey. Surprise, there weren't many other Indian American people there. So we go out in the town and, hey, you must be Dr. Garg's family. My parents live close to us now in northern New Jersey. We came back after all of our training and living in New York for a bit. And we took my son out to a little gastro pub. He loves steak frites, so we took him out. And both sets of grandparents were there. And a few minutes into being seated, the waiter, probably was in his 40s, turned to my dad and he said, "Dr. Garg?" And I knew he was talking about my dad, not me. My dad had cared for both of his parents, cared for him as a teenager, and I could just see a little bit of that light. And it's not because of the medical care he provided. It's because he imparted this sense that he cared for that person. That I could tell there was some moment where that man as a young person felt a little bit seen, a little bit healed. And then with my mother, looking back, she suffered from undiagnosed and unmanaged bipolar disorder for decades. We experienced that as a family with a lot of social stigma, lack of understanding, emergent hospitalizations against her will when things got off the rails. And I can look back now as a physician over 40 years and say, I could think of her blood pressure and her hypertension, her diabetes and her A1C, and I could see the psychiatric hospitalizations, and I can see her kidney function go like this over decades. So for the last 3 years, she's been on home peritoneal dialysis, thankfully doing really well. My parents like to bicker about how well she's doing it or not every day, so they have something to talk about and do. I think we all have these experiences where you look at the healthcare journey, and there's just so much lost opportunity.
Absolutely.
It doesn't have to be that way. We have the science, the knowledge, the therapies, the interventions, the people. They're just not set up in the right way. I remember social workers, nephrologists, psychiatrists, friends and family members, and I thank God for the relief and the care and the support they provided every day. And so then as I became a physician, I've chosen to work in environments where I felt like we were giving people more of what they deserve. I started my career at One Medical Group in New York, practicing as a PCP. I thought, here's a model where people are getting more of what they want. They access information transparency, virtual appointments, good clinicians who are set up to practice well, and really loved that experience. I went on to Oscar Health, where I felt like that being in a weird consumer tech-focused health plan where it was the first health plan to integrate $0 copay, totally free access to telemedicine a decade ago. It's common now. And then I've spent most of the last decade in what we call value-based care, CareMore with Sachin and Liba for a brief period, and then CenterWell, which is the largest senior primary care group in the country, working with clinical teams. So the NCQA contracts are very familiar to us. We come at our clinicians throughout the year about where the care gaps are. And they take pride in serving their patients well, knowing they're getting the preventive care and chronic care they need. And then they argue about the data. The data is incomplete, it's not accurate. what about this? This patient has this other issue. They see all the nuance and complexity. And so to one of your points earlier, Peggy, there is this opportunity to take the quality measurement ecosystem forward, put the insights in an accurate and comprehensive way in front of the people who actually work together to improve health, and to go deeper.
Yeah. So you've had a big dose of NCQA for the past couple of days. And we've been in sessions. Vivek's been going to all the sessions that he can, but we've also been having meetings in between with some of our funders and with Mark McClellan, who's working very closely with CMS. There have been a lot of really rich conversations. And I know you're not ready to unveil your strategy yet. He starts in January, right? But I wonder, what are the 2 or 3 things that you take away?
I feel like I finally understand the state of healthcare data interoperability, and it's as bad as I feared. But you all are fixing it, which I'm really excited about. So I know what CQL stands for, and I can spell fire correctly. So I feel good to start in January. But as a clinician and someone working with clinical teams, I think patients think this stuff is all there for their clinicians, and it's not. So this community has a clear plan and vision, and I want to be fully supportive of that great work that's been started. And I want to get to the point where producing the insights is not the work. The work starts, the opportunity to help people improve their health starts at the point of having the insight. And there I think we unleash a totally new wave of meaningful, clinically rich insights that help patients and families, help clinicians caring for them, really understand health over time in a very personalized way. We've talked about chronic condition management. There's obviously HEDIS measurement metrics that are around how well is your diabetes or other conditions managed, but these issues compound. And to really inflect someone's health over time takes time. And so we need to look at their health and whether their conditions are optimally managed over time and make sure they're getting optimal care. That is how we bend the disease curve, the morbidity curve. People stay more functional. They don't end up on dialysis or with strokes or heart attacks that could have been avoided. So I think chronic condition management, and then obviously the tie to specialty care, because people see more specialists than they see their PCPs in a given year, especially as we get older. And so we have to reckon with the fact that a lot of what we used to conceive of as just being in primary care's domain is actually in mental health, and it's actually in medical specialty care, and we need to broaden and enlarge it. On the accreditation and managed care side, I think there's problems that are very apparent to people about the way health plans are set up. They're ghost networks. Just because someone's listed in the directory doesn't mean you can actually access someone. We have an opportunity to work with the community to say, let's plant our flag. What is that next aspirational vision? Because the standards are part guidepost and part instruction manual. They reflect this commitment across the community that we can be better and we can define what that looks like. And some of us are going to go for it. Yeah. So I'm excited about all of those areas.
So one of the big things that looms over our work is the public has some beliefs about high quality. There's a belief that if it costs more, it's probably better. I don't think that's the truth. I think that's often what people think. That managed care is there to get in your way. I was very impressed with Sachin Jain's presentation on Monday, because I think we're not going to win the hearts and minds of patients if they consider managed care to be just something that's about saying no. So I wonder, what is our role in this? I actually think there's a lot of discussion happening among plans because of the United CEO, that whole horrible situation and so on. But I wonder, do we have a role to play there? What do you think?
I think so. I think everybody who's an actor in the ecosystem has a role. And you're right, no one likes the current system. But to create transformative change is going to take everybody, and it's going to take some people to lead. The health plan space is probably in a moment where competing on the same dimensions is no longer sufficient. You know, things are kind of at set points. And so there are health plan leaders looking for ways to differentiate on patient and consumer experience, on the service level, on representing themselves as the whole person, or at least in support of the whole person. and then obviously working with medical groups and clinicians in service of patients. And so I think we need to mark that territory, Peggy, and work with everyone to say, what is that next vision? We can be better. And look, people aren't going to tolerate this forever. The math doesn't keep working forever. And it's going to come in different angles from consumers, from funders, from payers, and from medical group providers. So why don't we just get together and go there together?
Yeah, I think that's right.
I think we're done. And I'm going to welcome back our board chair, John Glazer.
Oh, okay.
Thank you for this conversation.
Okay. Reflecting on my conversation with Vivek fills me with confidence about NCQA's future and the mission we all share. But I think that we need to think of this as relaunch of the original mission of improving the quality of healthcare. And the reason I say that is because I think we have a situation that really calls for more out-of-the-box thinking. First of all, the costs of care. It always feels like an emergency, but this time I think nobody can really understand how we're going to keep paying for what we're paying for. Second, the results are not what they need to be. Third, quality measurement needs to be more integrated into the care delivery process, and it needs to be more engaging for the people who are delivering the care. I think Vivek is the right person to bring about this next phase. He brings heart and humanity to his work. Quality is in his DNA. I'm convinced he's the ideal leader to advance NCQA's mission and shape the future of healthcare. With Vivek at the helm, the quality community will continue to innovate, collaborate, and advocate for better healthcare, better choices, and better health. Thank you for listening to this podcast series, and thank you for all you do to improve healthcare.